Good afternoon, everyone. Thank you very much for joining us here at HealthMonics as we are going through our latest in our webinar series, and specifically this time, how to impact MIPS costs as a large group or health system. The program is getting harder, and here at HealthMonics, we are here to help you. Thank you for attending on this in New Jersey and Pennsylvania right now, a brutal 100-degree day. Today, it will be myself as well as Lauren Patrick, our CEO, that will be going through this presentation. Hi, Lauren.
Hi, Mike. Let's hope my voice holds. I think I have
Uh,
laryngitis.
Oh, no. All right. So you might hear a lot of Mike today, and I'm speaking about myself in the third person, so we're all in trouble. A couple updates for you and a couple of background information. Ask your questions. We have a question section down the bottom. If we don't have the time to them, or I don't have my expert Lauren on voice working, we will get back to you after the call with all of your answers. As well as you can see on the handout side of the screen, you will see that I have put a number of handouts in there, including the slide presentation and some information about our MIPS tool, that MIPS cost tool that we have. So also on top of that, I will be sending an email to all participants, those who are here or not here, the webinar video, as well as the slide deck following this call sometime this afternoon. So please feel free to reach out to me if you do not receive it. Otherwise, you'll be able to have it here. So a couple of the things that we're going to review today: the fundamentals of MIPS cost performance category in 2022. We did do a webinar on the MIPS category of cost before. This is a little more leaning towards what you're going to need from a large practice or specialty practice or a hospital health system. Challenges for multi-specialty groups and health systems, and then what's driving your cost score and how do you maximize your performance, as CMS has taken the cost score kind of away from you in previous years, and the last time you really saw an impact was when it was only 5% of your score. Well, now it's going to be 30% of your score in 2022 and beyond, and that impact can severely change what your MIPS scoring is. For instance, right now this year, 75 points to avoid the penalty, with 30% of that score coming from cost. If you do poorly, it can put you in a precarious situation. So what is the cost category? It's designed to evaluate the cost for Medicare patients. So CMS is gonna CMS to come up with each one of these measures. Basically what they did is they found their highest costing categories, and they came up with measures to help control those costs. There are currently only 25 measures. However, there is an anticipation that there will be more and more over the years, especially with the introduction of the MVP program that's starting in 2023, where different specialties are going to be able to report all in one category set, but they do need a cost measure to be included in that. It rewards eligible clinicians for cost-effective care. So it will compare you to your peers. We have shown people differentiation between them and the peers within their organization, as well as comparing it on the national level to show you kind of where you stand. CMS uses claims data, so there's no actual submission needed. You don't do any submission in this program. What you do here is that CMS will take that claims data and calculate a score, and at the end of the year, when they give you your final preliminary and final scores, your cost score will be added in there. And you're benchmarked against other eligible clinicians. So we have enough data within our program to give you actual benchmarks. However, benchmarks aren't set in stone until all data is collected for the whole year. So it did mention that it is 30% of your cost score this year. That was mandated by the government to happen by this year. And I don't know what these question marks are, but this should be 10%, 10%, 20%, and then 30% right here. I don't know how they turn to question marks. Um, so you can see that it is becoming more important, and it is on par. I think the most important from this screen is that it's on par with your quality score, as quality has been something that we have been working with our customers and I myself for the last 10 years on your quality score, and I see the impact and the work that gets done by practices and organizations for the quality. Now that you can see that cost is the same, we expect that more and more organizations are going to be doing more to do a better job with their cost score to help compete with these programs. Cost score is reduced to 0% for APM entities reporting through traditional MIPS. So those people that cost score will be moving into the quality category. For the cost category scores, you need to hit minimum cases. So each one of the measures has a minimum case of volume. If there's no minimums met, the cost category will be reweighted for you. So I'm not going to dig too deeply into a couple of these slides. I added them in here for your reference after the webinar. This is one of them. These are who is going to be impacted by the cost category, and this is current 2022 information. Obviously, as things change, there will be more specialists that are added to this list. Actually, there are a couple that are missing in here. Dermatology is not on this list as well, and that will be, you'll see they are new to the 2022 scoreboard with a melanoma measure. There are currently 2 population-based cost measures. Those you might be most familiar with. So that's the MSPB, or Medicare spending per beneficiary, and the TPCC, which is the total per capita cost. Those were the original cost measures, as well as the most prevalent, as more people are going to be in those categories than any of the other measures. And then there are 23 episode-based cost measures coming from the 15 procedural, 6 acute, and 2 chronic care measures that were added this year. Performance for the TPCC measure is for the calendar year, but the MSPB and the other episode measures could travel through the years based upon the trigger period and prior 90 days and the following 90 days. So challenges for multi-specialty groups and health system. Multi-specialty groups are often scored on cost category. Their biggest challenge are the lack of clarity to what measures will apply. There's 25 possible measures, 25 measures right now, and 5 more being proposed for next year. So there are a lot of measures that could be attributed to each one of your groups. How do the measures get attributed, right? So not only is it hard to tell which measures you may be attributed for, but it's also hard to tell which patients are attributed to you or another provider group. Are they attributed to more than one group and more than one physician? Patients can be attributed to multiple physicians and multiple groups for individual measures. They also have the ability to have the same patient could be attributed to you for multiple different categories within different cost measures. These are the minimums here. So each of the measures either have a 10 patient minimum, 20 patient minimum, or 35 patient episode, not patient episode minimum for you to get the attribution. Multiple measures being applied to the group. There are many factors that weigh in, and you need to select areas of focus. Even for measures, for instance, that have even for measures that, for instance, have a minimum, you're going to see things come up for where the TPCC or the MSPB may have thousands of patients, but your melanoma measure only has one patient or enough attributed patients for it to count. But in the end, they're going to be scored exactly the same. So you can see that right here at the bottom. And that's going to be an issue, because how do you pay attention to those 10,000 patients for MSPB or TPCC, and then those 30 patients for the melanoma measure? For each measure, CMS is providing no reliable way of estimating your cost score. They haven't given us a thing. CMS provides no prospective information regarding patients that are attributed for your performance year. So you don't know throughout the year who are your patients, who aren't your patients that are going to be counting for you. They really, if you look at what's available out there, there is not a great understanding of how the measures are scored. What is a good score? What are the benchmarks? That available information is not out for you guys right now. And the risk adjustment is by subgroup of the measure. So looking at the DRG, the type of procedures and other factors, really all built into each one of these measures, makes it very difficult to understand. I'll give a little caveat into what you'll see in a little bit from our screens and what we've done with this program, but the amount of background work that gets taken to build each one of these measures makes the quality reporting measures look simple. And as you know, quality reporting measures have a lot of ins and outs of them themselves, but these cost ones are big. Measures include costs that are often unseen by the attributed group. So you have all of the information from your pre-acute, your initial stay, as well as your post-acute. Post-acute length may vary based upon the patient, so it could go all the way up to 90 days for each one of these. I'm going to throw it over to Lauren. Hopefully, if she has a little bit of a voice, she'll discuss the next couple of slides.
Sure. Thanks, Mike. Well, maybe I don't have a voice. I'll try really hard to talk and not hurt your ears. So the American Medical Association, along with HealthMonix, has recognized that not having those scores and not having any data to go off of is really, really an issue for physicians and for physician groups throughout the U.S. So they have written strongly worded letters to CMS, supported by many other specialty groups, and made specific recommendations. So we are all trying really hard to get CMS to release data regarding the impact of COVID-19 on the MIPS cost measures. We know that CMS has that data. We know that they've done analysis on it, but we also see that they're not willing to release it to the rest of us. CMS finally did publish cost measure benchmarks for, I think, 2018 and 2019. You can see those on the QPP website if you're interested, but they don't provide any more current benchmarks, and they don't provide any attribution information. So again, people are really working in the dark, and we're all trying to get CMS to release more of that information so that doctors can do what they need to do in terms of, working towards achieving better cost metrics. We're also looking for CMS to provide an interactive, affordable way for physicians to analyze their MIPS feedback reports. Right now, if you get a feedback report, which you are not getting for 2021 for cost, it is in the form of these spreadsheets that are very hard to analyze. We've seen some of those for prior years, and we've worked with providers to help them understand it, but it is not something that the normal practitioner can really work through and understand. And the other issue is CMS still has not released the 2019 data from the reporting of MIPS, both for quality and for cost. And so we're all pushing really hard to get that data. All this to say, there is really little visibility and transparency into how these scores are being calculated and how they're going to impact payments going forward. Mike, do you want me to continue with my voice, or do you want to take over?
I'll try to take over, and then you could discuss. You can pop in if you want to add. She definitely is the expert of this, but I've been doing it a long time too. So this is an example of what it looks like when it comes to benchmarks. What you're looking at here is the 2019 MSPB benchmarks. What you can see are the deciles. We have the 1st through the 10th. You obviously want to be in the 10th decile, which are the lowest cost scores there, and that's going to give you the highest scoring when it comes to these MIPS measures. So you can see the gap is pretty huge. It's almost triple the size between the highest boundary and the lowest boundary for the score. So you'll be compared to your peers here and given an individual score for each one of these measures. The average cost for the MSPB in 2019 was around $22,000. You also, as I did mention earlier, you need to meet the case minimum for at least one measure to get a cost performance category score. And for this case, you need to hit the case minimum for this individual score. As another example to show you what we have here, and you can see pretty drastically the cost difference, but this is for the colonoscopy benchmarks in 2019. You can see the lowest score here is 672, and all the way up triple the size of the higher boundary for 1,887. So what you'll see, and I don't know if I have it on previous screens, but most measures are going to only be attributed to a very small percentage. I think it's less than 1% of patients will be attributed for a number of less than 1% of providers will be attributed to a number of the measures. However, that number drastically increases when we talk about MSPB, TPCC, the diabetes measures like that have a very large population and many different types of provider types that do that. Here's an example here of what it looks like to be attributed multiple measures for an individual group. This is an actual individual group and their overall score. What you see here are the number of eligible cases for each one of the measures, as well as what your cost scores are for each one of them. So where the national mean, where you stand, and then what your decile score. So you can see, for instance, on the top line, we have a TPCC score that your episode cost is $5,000, while the national average is $14,000. So according to the deciles, that moves you all the way up to a 9.7 score out of 10. What you see on the next line is exactly opposite for MSPB. You have a very high per capita, almost $40,000 compared to the national average of 18. This gives this practice facility a 1 on the decile score. All of these scores are added up together and then divided by the number of measures that you are attributed to give you your percentile. So I think I showed that on the next page. So here, in this example, you see your total score. You have the 9 plus 4, 4, and 5 gives you 23.5 out of a total of 40 points. You take that and you do the math, you get 0.5875%. Then you multiply that by 30, which is your percent score, what percentage cost takes of your MIPS score, and that will give you the amount of points that you get for that MIPS category. As you can see, what I was telling you example on the previous page, each one of these are worth the same exact amount as each other. However, you're going to have, thousands of patients in the total per capita cost, but maybe only 100 patients or so in the knee arthroscopy. Sorry. So you have the impact on each one of these measures is important to look at from a whole standpoint. So what is impacting your MIPS score? As I said, there's 25 measures that we talked about. The attribution is based on providers and specialty services. Episodes are triggered based on services that are billed. So it's billed, not paid. Make sure that you understand that part. Additional services are assigned to episodes based on trigger event and timing. There is risk adjustment. So I talked a little bit about this earlier, but if you have sicker patients, it doesn't mean you have a higher cost score. Those scores will be reduced based upon risk throughout the entire program. Measures are calculated based on average of all the episodes, and then all applicable measures are scored an average to give you your cost score, which we showed on the previous screen. So what is impacting your cost score? So these are the new cost measures. So it says 2021, but as we know, 2021 was taken away. So these are the 2022 new measures. What you can see here are each of the measures and what specialties they're going to be mostly attributed to. So for instance, you've taken a look at the diabetes measure, internal medicine. There was 30,000 number of TIN and MPI combinations and over 1.5 million episodes for diabetes. And then the next one, as you can see on the next line, how to read this chart, family practice is the next group, and then nurse practitioner. But then if you go and take a look at the colorectal surgery group, you can see the number of TIN MPI combos, 292, a much lower number. There was less than 8,000 episodes out of all the Medicare patients seen during the year that are going to be associated with colorectal, but you do have to add the general surgery and the physician's assistant. So you can see that this does spread across very wide range of different types of providers and where they are going to land. And this is just for the newest measures, but each one of the measures has this type of breakdown. So the biggest thing, and for most of the people that I saw that are signed up for this program, is that you have many different types of providers. So for instance, if you have internists, family physicians, primary care physicians, you're going to have a number of measures here. It shows 6 that are associated with you. So you can tell that. But let's say not only do you have those type of providers, but you also have surgeons. There's another 20 measures that are associated with surgeons. Now, I'm not going to dig terribly deep into each one of these, but you can see they really go from everything from a knee arthroplasty all the way to diabetes. Is a very wide range for certain specialties, as you can see. And for most of the hospital systems, they also have hospitalists that are working for them that will cover the other measures. So we've seen in our work up to 20 measures that have been associated to one tax ID, and as little as one. Some of the specialists will only have one measure attached to them. So really the big thing is to understand where your scores are coming from and make the impact across the entire board. So this is all available for you to look at in our program or on these slides when I send them to you afterwards. So I'm not going to spend a terrible long time on those. Here's another one. So this is kind of like all the other ones. And I did quote marks with my hands that you guys couldn't see. But allergy, immunology, you take a look and then you see on the right-hand side what measures are associated with them. Urology, you can see there's 2 measures. Pulmonology, there's 4 measures. And each one of these categories have a number of measures that are associated with them. So what is impacting your score? So it's understandable what patients are attributed to you and what they're doing, but what's impacting your cost score? So you have the pre-episode trigger care, right? So there's the period, it varies anywhere from 0, so there could be no pre-trigger, all the way to 90 days depending on the measure. And that there can be associated costs that creep in. So understanding during that pre-acute period, if there were hospital visits or if there were skilled nursing facilities or there was some types of treatment that were pre-trigger for a knee arthroplasty or another one of those measures, they're all could count towards your overall scoring for that measure. Then there's the acute period, so the procedure. So the big things that could impact that score are going to be your place of care, right? Is it at a hospital? Is it an ambulatory surgery center? Is it in your office? I mean, I know, from my experience, they could be almost anywhere for some of these different measures. There's adjunct services cost. Do you have, if you need to have different types of doctors that are working in there, different types of procedures, things like that. There's new protocols or physician protocols, lack of definition. There is basically what it's saying is things can pop up that are going to be attributed to that patient that's during that acute period. And then there's the post-acute care. So a period of time that varies from 14 to 90 days. As I said, it can leak into a previous year or a follow-up year in this case. What the discharge status is, where are you sending them for post-acute? So big thing that we see that impacts this is what skilled nursing facilities are seeing these patients, and there's a very wide range of costs that happen at different skilled nursing facilities that can impact your score. ED visits, does the patient need to come back in, readmissions? Those can all add up, and when you're talking about each of these episode measures, they all can be associated to you as the provider. I know we hear a lot of, well, my cost is my revenue, but in this case, this is cost that is being attributed to you, but you're not seeing anything from it. So it's not your revenue, and you want to make sure that you are sending people to the right places and that you're working with the right group of doctors in the community that's going to give the best and the most cost-effective care to your patients, because it will impact your overall score. So what can you do about your cost score? Uh, Lauren and I had a good joke about this, but step zero is a new terminology for me, but it's what do you do beforehand? How do you get started? So this isn't even step one, this is before step one. You have to involve your physicians. Your physicians need to be part of this. They need to buy into this, or else this isn't going to work. This isn't like quality reporting, where you could have nurses and front staff and medical assistants and intake people that answer these questions to get you a good quality score. This needs to be the physicians that are doing that are bought in and they're engaged in this program. So you need to be able to provide them with valid and actionable data, um, be able to show them where they stand, how do they compare to their peers, what did they do better. You need to empower physicians to select or design clinical protocols. So let's say you have one provider that's has a very good score for one of the categories. What are they doing different than the other providers? And can you set up protocols within your facility for that? Ensure that physicians are understanding the importance of accurate documentation. As I stated, all of these measures get rated based upon risk. So are they putting the correct codes in to make sure that these patients are attributed, not only are attributed to them as a provider, but are also attributed their risk score correctly so that they don't cost you as much. And then, my big thing when I worked in consulting for a number of years was plastering scorecards right on the nurses station and showing peer to peer where they stand. I could tell you that every doctor I ever met when it came to competition never wanted to be on the bottom of one of those lists. And maybe that is a way that you can help them with their scorecards. And then let the physicians manage themselves. So let them talk to each other and figure out ways to do things. We're not here to tell you how to be doctors. That's not our job here at HealthMonix. And a lot of time from an administration standpoint, you don't want it to be your job. Let them do the work and let them find ways to do this. Now, all of that is to get us started, right? We haven't even started really what can you do and how do you impact it. So step one is identifying your targeted areas. What are the costs that are included in your score? Where are the costs coming from? And where are my costs higher than the benchmark? So understanding who's attributed to you, what measures and what patients are attributed to. Identify where your costs are high compared to your benchmarks. So you could do that by measure, you could do that by provider, you could do it by specialty patient cohorts. If you want to look at diabetics that are attributed to you for the TPCC model, if you want to look at people that are of a certain age or from a certain race or ethnicity, you could do that through different programs, most likely ours, because we're the only ones out there right now that are being able to provide that information to you, to really take a look at where do you have patients that are being underappreciated. Think of the word there. Identify cost variations in your practices and determine where best practices exist. We talked about that. Drill into high cost patient groups. Do you have something that stands out? Are your diabetic patients more expensive than anybody else in the market? Are your patients that are seeing certain doctors more expensive? Break down patients and providers into subgroups to analyze them and really understand where this data is coming from, where it's going, and how you can make the impact on it. Also, part of step one here, what you see is an example of what it looks like in our system, comparing practices to their providers to each other, what it looks like from an episode count. So you see here, you have someone that is in the second percentile, right? The first provider up at the top, and then comparing that to the provider down the bottom that's in the fifth percentile. How do you get that fifth percentile provider to work with the lower ranked provider to get them on the same page, to get them understanding where their costs impact? And maybe it is an HCC issue, or maybe they are doing things that aren't needed. Lauren, do you have anything to add on this screen?
No, I think that at this point, what you do is you need to drill in, as you're saying, to look at where the variation's coming from. So if you identify, in this particular case, we do see that it's at the procedure level. It's not post-acute necessarily. It's not pre-acute, although I don't think colonoscopy has a pre-acute period. But yeah, in this case, you'd want to look at, so what's happening during the actual colonoscopy. What is getting billed for those episodes, and then analyze that variation and see what you can do to normalize it, because that is even though it's only a $200 swing there, it does take you from essentially a 5-point measure to a 2-point measure. So there's something there to be looked at and gleaned, and then perhaps make changes in your practices.
Got it. Thank you. So what can you do about your cost score? Step 2, identifying the root causes of your issues. Why are my patients' costs so varied? Are patients receiving the best care? Where are the patient costs? How can they be reduced or changed? So here you're going to drill into costs from external services, unneeded services, EDs. I know, we've been brainwashed. I don't want to say brainwashed. It's been drilled in a number of times that patients that are coming back for readmissions, that are coming back for ED visits and spending a lot of money on post-acute care is what's costing our patients a lot of money when it comes to expenses. So those have been kind of drilled in us, but this is showing you the data. Costs are showing you the data that actually shows what you are doing and how you're doing. Identify cost variation in your practice. So the best practices, identify the underserved, that's the word I was looking for earlier, patient cohorts by principal diagnosis. Preventative care is big. Is it bringing in people for the pneumonia shot and making sure all your patients have the pneumonia vaccination? That's going to help you reduce your pneumonia vaccine, pneumonia measure that you have. Drill into high cost patient groups, break down patients to subgroups. Reviewing your HCC scoring. I've talked to a number of hospital systems that have now hired multiple people to take a look at their HCC scoring and make sure that they are coding correctly. There are groups and organizations that will take a look at that for you. That could be really important from everybody from the solo provider all the way up to the large hospital groups. And then analyzing high cost external services. All right, so you have a wide range of facilities that are available to you that are outside your care for skilled nursing. And some of them have higher costs than the others. Deciding where does the cost of care fit in? How are you doing that? Talking to them, maybe making sure that your providers are recommending a certain facility over another facility based upon their quality and their cost scores, and utilizing tools from HealthMonix as well as our consultants to identify measures, specific opportunities to optimize. Working with us, we could give you multiple stepping points and areas that you can take a look at different measures and where you can make an impact today, instead of kind of sitting back and letting CMS do what needs to be done and having very little impact on your score. So the first step, right now we're on step 3, but this is the first step, is identifying an action plan. So what can you do? You got to get to work, right? Reducing variation in treatment. Big thing between providers, get them all on the same page. Identifying underserved patient cohorts, identifying your gaps in care, being able to see what's missing from these patients from a preventative standpoint. Eliminating unneeded services, choosing wisely or using the CMS guidelines. Reducing ED and readmission visits. Choosing appropriate post-acute care, analyzing high-cost external services to determine value to cost. So, a lot of this we've gone over, but you need to identify an action plan for what you need to do and utilize our tools. So a little bit about our program. I kind of got through this a lot quicker. This is a great opportunity if you have questions to get questions up here. Otherwise, you can always reach out to us to ask your question. So this is a little bit about our MIPS cost analytic tool. MIPS cost analytics is the first and only technology platform that is pulling current year patient level data for your Medicare patients to give you not only an accurate MIPS cost score, but also access to that claims information. So what can it do to help you with costs? It shows your estimated MIPS cost score throughout the entire year, so up-to-date information on a quarterly basis, providing you actual insight into each of the cost measures. identifies your anticipated attributed patients and episodes, so really pinpointing you with who you really need to be working with. Shares individual patient HCC scores, so you can see the impact of your risk on each one of these patients and what you're doing from a coding standpoint. Allows you easily to identify those patients and providers that have the largest impact on your cost scores. Here's an example here of one of the dashboards. You kind of saw a little glimpse of this on a previous screen, but what you're seeing here are the measure summaries. So you got your total per capita cost up at the top, all the way through all of the episode measures below, what you're looking at from a per capita standpoint, and then what is hitting you for the benchmark compared to your actual costs, and then what your decile scores and your potential score. So once added together, we can give you an accurate MIPS cost analytics score. This is a breakdown taking a look at TPCC by provider. So each one of your providers here listed on the left-hand side of the screen. And then on the right-hand side of the screen, you'll see your TIN comparing to the overall scoring in the system. This is broken down as well by patient. So here's an example of Mary Smith and all of the claims that are associated with you. As you can see in blue outline here, with the claim information, you can see that you could click into this and see the actual CMS claim to understand it even better within the program. Here's an example of what a provider snapshot would look like, showing all the measures. This case is showing TPCC and MSPB. Who are your top providers? Who are your bottom providers within your organization, and being able to compare them to each other, including the number of episodes and what their impact is on your overall score. So this is available within a analytic tool that really allows you to dive into data from all of the individual measures that we have. We do have more webinars coming up in August. This is an interesting month of the year in July with vacation time, so we'll be putting on a number of webinars in August, so please stay tuned for that. For more information on our cost product and or our MIPS product, please reach out to contact@healthmonix.com. That'll go directly to me, as well as the phone number that you see there will go to my team. If you have any questions, please reach out to us and we'll get started. So this is a good time if you have questions to get them to me in a minute. Before we get to questions, I should have thrown it over to Lauren and asked her if there was anything that she wanted to discuss as well. So Lauren, is there anything else that you want to discuss?
You know, there's lots, but I don't have a voice, so I won't pain you guys with listening to me today.
All right, terrific. There are a couple of questions that are in here that are more of individual questions that we'll respond to you on your time, on our time later today, or first thing tomorrow. You'll get the response form. So I appreciate everybody's time. Sorry to cut this short, but I talk a lot faster than Lauren does for the most part. So I go through it a little bit quicker. So if you have any questions or concerns, please feel free to reach out. But it's been wonderful speaking with you today, and we look forward to working with you on your cost scores moving forward. Have a wonderful day, and talk to you soon. Thank you.